problem feels really big, but don't let that stop you from starting somewhere.
When something is so big, it's hard to see where your place within it lies and what you can do. And I think it's really surprising to me that almost a quarter of the NHS carbon footprint is just medication.
The problem with carbon footprinting is it often encourages us to focus on products and not think so much about diseases and how to care for patients better.
Hello and welcome to the Paeds Round, your official podcast from the Royal College of Paediatrics and Child Health. My name is Emma Lin and I'm a consultant paediatrician at the Great North Children's Hospital. And on today's podcast, we will be discussing why sustainable healthcare is an issue and why we all need to be not just interested, but engaged in it. I'll be talking to my guest today, who is Dr Emma Parker, who recently completed a Sustainability Fellowship at the Great North Children's Hospital and is now the Royal College of Paediatrics and Child Health Clinical Fellow with the Clean Air Fund Partnership. So welcome, Emily. What a lot of titles. And do you want to introduce yourself in a more friendly way?
Hi, Emma. Thank you so much for having me on the podcast. I'm really excited to be here. I don't hold all those titles. They're just jobs that I've done. But I seem to be the eternal fellow because of the interest that I have outside of medicine. So these jobs have enabled me to carry on practicing as a doctor while pursuing my interest in sustainability.
We ought to get the conflict of interest out early on. And I have to say that I was your supervisor in the year that you were a Sustainability Fellow at the Great North Children's Hospital, and which was a project that was inspired by Dr Mike McKean, who is the current Vice President of the RCPCH. And also you were supported by the Centre for Sustainable Healthcare.
Yeah, it was great to be supervised by you, Emma, and amazing that Mike managed to get that project through our charity funding in Newcastle hospitals.
And actually, I do credit you with making me so much more aware of ways that I could make a difference, because I think it's very easy to get sucked into the day-to-day running of the hospital and looking after your patients and not having time to think about these really important bigger issues.
That's really interesting that you hadn't thought about previously. I think I share that as well, actually, that it was the Sustainability Fellowship that has really inspired me to apply my understanding of the environment and its importance to my work as a doctor. So it's a journey that we've been on together as well to some extent.
That's nice. That makes me feel part of it. And I think one of the big targets you always talked to me about was the NHS net zero strategy. Do you want to explain a bit about this?
Yeah, so the NHS was the first healthcare system to enshrine its net zero policy into law, and that happened under the Health and Care Act in 2022. And there is a Greener NHS organisation that sits within NHS England that's responsible for implementing net zero, and that covers the entire system of the NHS. So it includes buildings, transport, energy, and then all of the things that happen within the clinical pathways that we do. So the medications we prescribe and the machines we use, and then all of the administrative side as well. So it's a huge area of work to try and reduce the environmental impact of that system.
And I think when something is so big, it's hard to see where your place within it lies and what you can do. But one of the things that you explained to me is that medicines and medicine prescribing is a huge part of the carbon footprint of the NHS.
Yeah, so medicines. So there's a really interesting graphic that Greener NHS has produced. And even if you just Google net zero NHS, you'll find this graphic. It's green and blue, and it's a pie chart that shows the different parts of the system and their contribution to the carbon footprint. And medicines on that graphic take up 20% of the carbon footprint, medicines and chemicals. And then there's a separate part for inhalers and anaesthetic gases, which is another 5%.
And so I guess that was one of our projects where we thought about the difference between prescribing pills and prescribing liquids and the effect that that could have on that 20% of the carbon footprint. So tell us about that.
Yeah, so we were thinking a little bit about what we can do as clinicians and where our areas of influence lie. And you'd already undertaken this really interesting teaching programme helping children to learn to swallow tablets called KidsMed, which I think members of the college might already know of because it's being promoted through the college. And one of the areas of KidsMed that hadn't really been looked at in detail was the impact on the environment. But we had a kind of hunch that there might be some significant differences between tablets and liquids, partly because the cost of them is already so different, and that suggests that the processing might be quite different chemically. So we wanted to try and investigate that. So I undertook a project looking into it.
Go on then. Are you going to tell us the results? What happened?
So we started off looking at the most obvious thing to us, which was the packaging. And I think the process of this project was quite interesting for all of the team to look at, because it represents a common error that we all make when we think about sustainability, which is to focus on waste and the stuff that we can see ourselves throwing away. So I started by weighing the packaging out and working out how much carbon each piece of packaging represented. And we found that there was already quite a big difference between tablets and liquids based on the packaging, and that liquid bottles with all their packaging were about 3 times the carbon footprint of the small packs of tablets, which if you think about what's in them, you can imagine that that might be the case. But then actually what happened after that was that we combined our project with UMaker's results.
Well, it's a perfect time to talk about this because UMaker is a company which has just very recently published their online formulary, so that in exactly the same way as if you use the BNF, you can look up the price of different drugs, you can now use the UMaker formulary to look up the different carbon footprint of drugs. And this is all the brainchild of Dr. Nazneen Rahman, who got in touch with us.
Yeah, she got in touch via Twitter. You've just reminded me of that. That was how we collaborated with her, and we can thank the college for that, because I think she got in touch with me or you on Twitter after we presented our initial findings at the college, and we'd maybe tagged her in something or something like that. So it's a good story. But she basically was very kind and shared some of her results with us about the carbon footprint of amoxicillin, so the molecule that goes into the drug of amoxicillin, which is the drug that we'd chosen to look at for our packaging. And we were astounded when we looked at the results that she had compared with our packaging carbon footprint. And I think we had to recheck it about 10 times because we couldn't believe that it was so much more than the carbon footprint of the packaging. So what I was talking about earlier is this story of focusing on the things you can see and forgetting about the things you can't see. And that actually, once we looked into the things we couldn't see, we realised that it was much more important to care about drugs wastage than to think too much about the packaging when we're talking about carbon footprint, if that makes sense.
Thank you, Emily. And I think it's really surprising to me that like almost a quarter of the NHS carbon footprint is just medication. And that means that we've got to think so much more about how we prescribe. So we wanted to look at this in a real world scenario, and we looked at the example of prescribing a course of amoxicillin for a child with a sore throat. And tell me what you found out just looking at that real world example.
So it was really interesting starting this project off because we tried to find any research that compares liquids and tablets and looks at the carbon footprint. And I think there was one study that was done in India looking at paracetamol, but it was done on a huge scale and it wasn't actually done by clinicians. So we were the first clinical team to try and do this that we're aware of. And what was really fascinating to me doing this research is that you initially focus on the packaging because that's the waste that you can see. But when we applied this clinically, what we found was that tablets allow you to prescribe very specific numbers and to adapt that to the course that you're prescribing, whereas bottles are extremely difficult to divide up and we can't do it. So when you prescribe a course of amoxicillin with bottles, you have to prescribe 3 bottles for the child that we looked at in our example. So that's 10 doses in the first and second bottle that she would take over a 21 dose course. And then for the final dose, she needs a whole bottle just for that final dose. And you probably would find that maybe the parents would pour 9 doses in the final bottle down the sink, or give it to a friend who probably hasn't been prescribed it.
So that's really fascinating. I think this is a really common problem, that we prescribe liquid medication and we don't really know what people do with the bit that's left over. So you were saying that quite a lot might be left over. Mm-hmm. And I think another of my trainees looked at that and found, on average, with 6 different types of antibiotics, that half the bottles were left over at the end of the course. And that leftover medicine, like you said, either gets tipped down the sink, which obviously is putting antibiotics into the water and increasing the risk of antimicrobial resistance, or it sits around on the shelf and then somebody decides to use it because it might just help somebody else who's ill or the child that's ill again. So that's inappropriate use and again risks antimicrobial resistance. Or they return it to pharmacy. But quite honestly, I have 4 children and I've never returned anything to pharmacy. And the only time I tried, it was the EpiPens and they refused to take them. So we talked about the wastage of that medicine compared to giving pill doses. Mm-hmm. Could you put any figures on that in terms of carbon footprint and money?
Our project focused on the carbon footprint. And what we found was that in a 21 dose course of 250 milligram doses of amoxicillin, the final bottle, you waste 9 doses. And those 9 doses are equivalent to about 6.6 kilograms of carbon. And that's the equivalent of driving a small car 99 miles, which would get you from Newcastle to Edinburgh. And that's just one course of antibiotics for one child.
Yeah. And overall, we found that liquids were, on average, 40 times more expensive than pills for the same dose. So there's a huge difference in cost. And we were just looking at antibiotics. So what would your recommendations be then, knowing what you know now? How has that changed your practice?
I think it made me think a lot about the communication between doctors and pharmacists, because I imagine that pharmacists are very well aware of how much is wasted in the final bottle and have been for a long time. So we probably really need to facilitate a conversation when we're prescribing that allows pharmacists to come back to us and say, are you sure you want that last bottle? The patient's only going to be using 1 dose of it. And I guess we also probably need some help from our infection control colleagues, of which you're one, Emma. So maybe you can provide some guidance on how we might dose antibiotics if there is just such a small amount needed from the final bottle of liquid.
Yeah, thank you. And I did a really nice project with Joe Pickles, who is one of our medical students, and he looked at the antibiotics and he found on average 50% of a 100 ml bottle is wasted for every course of antibiotics. And that financial cost is £2 per course. And as I said, the liquids cost a lot more. And we had a couple of recommendations. First of all, as you say, work with your pharmacist. And the most obvious thing was to use an IT solution. So just to put the pills as your first choice when you prescribe, most people are using electronic prescribing, and most people click on the thing that's on the top. So make the first choice pills. The second thing that we thought about is just thinking whether it makes a huge difference. So whether you can have 20 doses rather than 21, which we know wouldn't make any difference. But that would have to be a system change. And we considered talking to the people who make the guidelines. So thinking about contacting the British Paediatric Allergy and Immunology Group to see if we could change national guidelines. So that's a system level change. But also some really simple things like some bottles like flucloxacillin come in actually not flucloxacillin because it's so disgusting. Nobody should ever prescribe flucloxacillin liquid. It should only be prescribed as tablets because it tastes so bad. So I'll take a different example. We were talking about amoxicillin, comes in 2 strengths. So it comes in 125 milligrams per mil and 250 milligrams per mil. So if you chose the stronger strength, for younger children, you might manage to use less bottles. So that was a really simple thing. Mm. And finally, to try and to engage with industry, which is something we don't do, and persuade them to to engage with industry and get them to give us antibiotic liquids, because you do have to use these in very young children, in bottles with smaller amounts in. So azithromycin is a really good example where they have 15 mils and 30 ml bottles, not just 100 ml bottles. So that reduces your waste a lot.
I think the really important message to get across, though, is all these complicated solutions are unnecessary if we can teach children to swallow tablets from a very young age. And using Kids Med, that solves all of those messy, kind of difficult aspects of changing the prescribing of bottles and changing the strengths of solutions, which would be important. But when children can learn to swallow tablets, we then have a box with 21 tablets in it that fulfills the course, and there's no wastage, and the parents can't give it to them in 2 weeks' time when they think they're unwell again, and it doesn't sit around in the cupboard or go down the drain. So
I'm glad you're a convert.
Yeah, that's what I'm into.
Yeah, no, I completely agree. And I'm constantly surprised and depressed by how many children don't know how to do it. So I was on call last week and there was 8-year-olds and 12-year-olds who couldn't swallow pills. And I think that we know that we can teach children from the age of 4. And one of the system level changes we're looking at is seeing whether we can get children to learn this skill through school, because it's exactly the same as learning to ride a bike. It's a life skill. It's something that we all need to learn. And so we're working with a group of pharmacists in Liverpool, in Alderley Hospital, to see if we can do a much bigger project to introduce it into the school curriculum, which would be something I'm really keen on. However, obviously, it's not all about pills, although you know I'm passionate about that. And you talked about inhalers and anaesthetic gases being 5% just by themselves of the NHS carbon footprint. And I know there is a huge amount of work about inhalers. So talk to me about our choices of inhalers, how we dispose of inhalers, what we're going to do with all these inhalers and asthma medication.
Okay, so there's been a big focus on inhalers in NHS net zero strategy, and that's because they're considered to be a carbon hotspot, which means that it's, I guess, a small part of the system, but a huge part of the carbon footprint. The reason why inhalers, metered dose inhalers, have such a big carbon footprint is because they contain gases which are very potent greenhouse gases. So in order to deliver the medication to the patient's lungs, these gases get released, and they are environmentally not good. So there's been a big drive to try and use dry powder inhalers instead of metered dose inhalers, because the dry powder inhalers have a different way of delivering the drug, and that's through the patient breath power sucking the powder into the lungs.
So that's a really important point. It's better to use dry powder inhalers than metered dose inhalers, because then you're not having the extra gases and canister within it.
Yeah. They don't contain these potent greenhouse gases at all. They just contain the powder.
So this is really important. We're talking about asthma medications and the different choices you can make, and how dry powder inhalers are better than metered dose inhalers. But they all use quite a lot of components, quite a lot of plastic and metals. So how do we try and reuse, recycle, and maybe later on we'll talk about reducing the use of them altogether?
Well, it's a big question. I think all inhalers are quite complicated to recycle. Dry powder inhalers are actually a bit more complicated to recycle than metered dose inhalers, because they're a more complicated design using different plastics. Metered dose inhalers, you can remove the canister, recycle the plastic, and then capture the gas left in the canister, and it can be processed and sold for non-medical uses, because these gases are actually quite valuable. But it's quite a complex system that is needed to do that, and there are some programs that exist run by Grundon, and actually there was a really good presentation at the Royal College of Paediatrics conference this year that talked about an inhaler recycling project that's been undertaken in London. And that was by one of the members of the climate change working group.
So that's really interesting. And I think that's a really important thing, that we sometimes do have to prescribe metered dose inhalers, and that we really need to be better about trying to recycle them and using these new systems and developing them within our hospital. So that's great. We've talked about how much more important it is to recycle metered dose inhalers. But actually, what we really need to think about is how to optimise asthma care. And how would we go about that?
I'm really glad you've asked me this question, Emma, because I think the problem with carbon footprinting is it often encourages us to focus on products and not think so much about diseases and how to care for patients better. So when we think about inhalers, I think it's really helpful for us to actually think about what diseases are we trying to treat, and how can we make these patients live better lives and have less disease. So one of the things we can do is, within asthma care, we can make sure that patients are taking their steroid inhalers and are appropriately prescribed steroid inhalers. And I think in paediatrics that can be quite difficult, because we have lots of children coming through, young children with viral induced wheeze, who get given a blue inhaler and they go home, and they probably end up staying on it with their GP, who repeats the prescription, but they haven't really been given good advice about when to take it and when not to take it. They've just been given a reducing course when they leave hospital. So I think one of the things we can do as paediatricians is think really carefully about those children and how they get followed up. Do we see them all when they're 5 and decide whether they've got asthma or not? And if they haven't, do we just stop the inhalers? And then make sure that those who have asthma do get steroid inhalers and have their disease really well controlled. So that's step 1, but I think we can go a little bit further.
I think this is a really good point, that actually the best way of reducing the amount of asthma medication you use is by having really well-controlled disease. So if you think about really well-controlled asthma, you're taking your regular medication and you're not taking so much of those short-acting beta agonists. But the other thing to think about that you touched on is all the children where they haven't necessarily had a diagnosis of asthma, and how they get followed up and how their care is really focused on. So I think that's a new area that we're much more aware of. And I know that on beat asthma, there are new guidelines for viral-induced wheeze in children where they're too young or they don't have a full diagnosis of asthma. So very, very important. But if we think beyond that, so we've talked about the drugs you use for asthma, we've talked about good asthma care, but we haven't yet got to the root of the problem, which is how do we stop people getting asthma? What can we do in a greater sense other than giving medication?
Yeah, and that's, I think, especially interesting from a sustainability perspective. If we take this approach of looking at the disease rather than looking at the products of healthcare, so we don't look at the product being the inhaler, but we actually look at the patient and their disease, is that asthma kind of represents an environmental illness, and it encourages us to really think about how the environment affects patients. And that's what's really led me on to the next role that I took after my sustainability fellowship, which is what I'm doing now. Because when I was looking at inhalers and finding it quite difficult to think about how to implement these changes, especially in paediatrics, where prescribing dry powder inhalers can be challenging with young children, I started to think more about what can we actually do. And I almost got a bit frustrated with thinking about these products because all the causes of asthma, or a lot of the causes of asthma, are actually preventable, and we can do so much more to try and stop people getting asthma. When I started to read the evidence, I was shocked that we knew that air pollution was causing asthma since the 50s and 60s, really.
So I think that's a really, really interesting point you bring up, that almost all diseases, while they have a genetic susceptibility, which you may not be able to change, there are also environmental triggers. And this is true in so many diseases, but what you're talking about in asthma is the huge part that air pollution plays in making this a disease of our current climate.
Mm-hmm. Yeah. So I guess that's made me into a bit of a public health paediatrics doctor, because it's really enthused me on how we solve the problem of the NHS carbon footprint on a slightly bigger scale. And I think it's made me think about this image that you can see of the pie chart and net zero, and how that image doesn't really talk about patients. And I think we really need to be keeping our clinical hat on and keeping our patients in mind when we're trying to solve this problem, rather than just thinking, oh, we mustn't waste. When we think about the how, we need to think about making people well and basically making our role not needed anymore, or at least only needed in very extreme circumstances, and that we have a healthy population.
Yeah, really interesting. So I guess there's a parallel between fast food and obesity. So you're talking about clean air and asthma, and not just asthma, all respiratory diseases, actually. And what kind of things can you do to promote clean air or to help your patients?
So we're actually working very hard on this at the moment in the college, trying to develop some really good advice specifically aimed at paediatricians, at children and at their families, in how to make changes that are going to reduce exposure to air pollution, but also potentially reduce contributions to air pollution. But there are things you can do. So simple things like, when you're walking to school with your child, that you put them on the side of the street that's furthest away from the cars, and that you choose routes that go on the back streets, so not on the main roads. Children are very vulnerable to air pollution because of their height, so they're often almost at the level of a car exhaust. And also because they breathe, their metabolism is different, so they breathe faster and they take in more pollutants per volume, per body mass, than adults. So their cells are being more exposed to the pollution. And then I guess closing your windows on high pollution days is another piece of advice you can give to patients. And those who really suffer from severe asthma, there is advice that they shouldn't be outside exercising on high pollution days. But I find these pieces of advice difficult, because what we're asking people to do is avoid nice things, potentially. And I think we need to be doing more to try and reduce pollution. So potentially, even within a hospital system, as a clinician, you might be able to influence your trust to help with things like active travel, to stop cars idling outside the hospital, and to implement the Clean Air Hospital Framework, which is something you can look up, that was developed by Global Action Plan and gives a number of points that hospitals can follow to make their hospital better for air pollution.
I'm really glad you have such big ambitions, and I guess that's really interesting that you've moved from a small thing, which is just prescribing something differently, to trying to change like government and high-level policy on what happens. I think in practical terms it is important. One of the really kind of demoralizing things that was happening in our hospital was our outpatients department faces right out onto the street, and it's exactly where all the smokers go to smoke. So they come out of the hospital and they all congregate just outside the children's outpatients to smoke. So they had a whole program of trying to remove them or move them to a different place. They've done a lot. First of all, they put all this advertising campaign, and it was really clever because they put lots of pictures of children holding signs saying, "Don't smoke, I'm just inside," which actually was, I think, quite impactful. They also put a fruit and vegetable stall very close to the outside of the hospital, so it's not really a place you would try and smoke and everybody's watching you. So whilst they haven't reduced the smoking, they have moved it away from the children's outpatient area, which I think is very positive. And I think that everybody can be thinking about things like this in terms of what happens outside the hospital.
Yeah, and to add to that, one of the things I noticed in Newcastle is that the children's hospital is right by the main road. And when they implemented the clean air zone in Newcastle, the parameter road of the clean air zone goes past the hospital, which I presume means that all the polluting vehicles who can't drive through the clean air zone could potentially use the road that goes past the hospital as their route to avoid the clean air zone. And I wish that I had been on the ball with this and got some air pollution monitors so that I could have shown pre and post levels of air pollution and argued that it was a bad policy decision to make the cars drive past the children's hospital.
That's fantastic, Emily. I mean, we've talked about so many big topics, from making every dose you prescribe count, thinking about how you prescribe both in terms of pills versus liquids and in numbers of doses, thinking about whether you actually even need to prescribe that antibiotic, thinking about asthma care and good disease control, as well as how you recycle and reuse your inhalers. And then on a sort of system level, thinking about advocacy and the importance of just being healthy and making our surroundings healthy. So promoting clean air, being ambitious, thinking about not just solutions like walking on different routes and closing the windows, which is, as you say, going around the problem, but tackling the problem head on by trying to reduce pollutants, reduce cars, stop smoking. So these are really, really big problems. So I'm going to ask you the most difficult thing, which is to give us your top tips.
So 3 top tips for clinicians in paediatrics who want to do something about sustainable healthcare. The first tip would be to think about where your power is. So think about your spheres of influence. And there's a really interesting diagram that shows personal sphere, work sphere, organizational sphere, and they get bigger and bigger. So what's your biggest sphere? Aim for that level if you can. My second tip would be that the problem feels really big, but don't let that stop you from starting somewhere. So even if that means that you decide in the morning huddle that you're going to have some kind of sustainability related piece of information that is shared by the group of clinicians that morning, that's a start. And once you start, you'll feel more positive about the future.
Yeah, I love your idea about the spheres of influence. And obviously, the Paeds Round, our podcast, is a huge sphere of influence. So We would ask everybody to listen and share the Paeds Round, because that will make your sphere of influence bigger and share learning. And I would also say to other people, particularly other people who are passionate about sustainability, come and find me, ask me, and I'm happy to do more and share their learning. I think that your point about taking baby steps is really important. Small things matter. And we do 1 minute learning. So every time I do a handover, at the end of handover, I try to do 1 minute learning. And it might just be something like you say, that actually think about air pollution. It's really important. Listen to our podcast. So I think that these things make people think about what's important. And you still got one last top tip.
Well,
Can I have?
You can have it. Yeah.
Okay, my last top tip is obviously prescribe pills, not liquid, and teach all children over the age of 4 how to swallow pills, because it's a life skill that matters.
That's a great tip. You can have it.
You're so generous. It's been a real pleasure to have you, and thank you very much. And I'm sure we'd love to speak to you maybe in a year's time when you've fulfilled some of your huge ambitions, or to talk to some of your colleagues as well. So
Great.
Thank you very much, Emily Parker.
Thank you, Emma.
This podcast is a collaboration between Medisense Medical Education and the Royal College of Paediatrics and Child Health. You can find more creative learning resources on www.medisense.org.uk, and of course a wealth of information on the important work of RCPCH on rcpch.ac.uk or #ChoosePaediatrics.
The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other group or individual.